Hospital Ethics Committee and faculty of the Berkeley Institute of Bioethics. And welcome you to our Ethics for Lunch today. We have a very interesting topic and panel to share with you. As you know, this forum is part of our effort to engage our community in issues that are of concern to all of us. And this particular one, in terms of cost of really expensive medical treatments, is one that I think everybody's thinking about these days. So what I'd like to do is introduce our panel and then turn it over to them. Tom Crawford, who is probably well known to many people, is a professor of neurology and pediatrics. He is known globally for his work in SMA, and had the privilege of working with him on a number of occasions, and he will, I'm sure, bring a lot to this conversation. Next to him is Carol Symes. Carol is a community member on our ethics committee for 25 years or so. She has a daughter who has cystic fibrosis, and she is well aware of some of the issues related to issues around expensive medical treatments. Next to her is Silvana Barone. She's a clinical fellow in pediatric hospice and palliative care in the Department of General Pediatrics and Adolescent Medicine. And at the end is Gail Geller, who's a professor in the Berkeley Institute of Bioethics and the Department of Medicine. So I'm going to, first, I believe we're going to begin with a video that will introduce the topic.
Well, just that, rather than do a setup, the Boston Globe recently did a story on this that I thought was almost perfect for this purpose, and it's professionally done rather than me. So I figured we'd do this document video as we're talking there. So I was particularly pleased they gave me the last word. So this has been an unbelievable ride. Some of you know me, whenever I started off in medicine, wanted to be a hospice doc, and I chose SMA precisely because it was hopeless. And I remember an attending physician when we saw one of my first babies. I think the first baby I ever held had SMA. And I stayed through the night, and I was interested in hospice kinds of things. And came time to present the case, he said something along the lines of, "This is so hopeless, we don't want to intrude on Mother's Street, and let's move on to the next case." And that kind of got my gander up. And so I learned more and more about it. And then we went to neurology and said, I'm going to do SMA kind of stuff precisely because it's hopeless. But I kind of like sciencey stuff. And so along the way, I was doing a postdoc here and ordered on things, and one thing led to another and another. And then we found the gene, found this backup copy of the gene, which is remarkable for SMA. The backup copy of the gene makes a little bit of protein, but not very much. But the reason why it doesn't make so much is something that you can imagine creating a drug to resolve. And the Biogen people came up with this really amazing idea, actually not Biogen, a researcher at Cold Springs, Harvard, named Adrian Craner, came up with this idea of a tiny little segment of synthetic DNA that is administered into the spinal canal. When he was initially trying to design it, what happens is it actually attaches to the message and causes the message that's aberrantly spliced to be correctly spliced, and hence make a normal full-length protein. I thought it was a great idea, but I remember telling Adrian that the stupid idea is there's no chance in the world that DNA will survive if you put it in a human body that's been cut by nucleases. And then there's a company called ISIS at the time, changed the name for some reason, and they had modified the backbone of the DNA so that it's now a synthetic antisense oligonucleotide, a 15-18 base pair piece that resists nuclease digestion. And so when you put it in the CSF, it doesn't get broken apart. But I still thought there was going to be a problem, because how is it going to get into cells? And we had another miracle happen, which is that when you put it in the CSF, it automatically gets taken up into cells and resides in the cytoplasm for reasons we don't know. So a huge 20-year problem was a non-entity. It was mooted by this remarkable tendency. So while SMA is incredibly lucky to have in the first place. The number of things that broke our way, the backup gene, the fact that we had animal models that recapitulated disease, the ability to have this new technology, the ASO technology that works, the fact that it's taken up into cells, the fact that we can measure disease, the fact that we have a large enough community to pay for it, are all things that most diseases don't have, and we have every one of them lined up just perfectly. And so Adrian Craner had this on his dry erase board in 2006. Grants were reviewed, all that kind of stuff. It went into cells 2006, 2007, went into mice 2008 and 9. First human exposure was 2011, first clinical trial 2013. 2016 was when the clinical trials were concluded. I have to tell the story. It's my favorite story. I was aware of these clinical trials. My patients were involved in, and I was in a plane flying to Africa with my wife, and I got a text message on my phone saying your trial has been stopped for futility. And I said, futility? Oh no! And close the doors, turn off the phones. You're flying to Africa 14 hours later. Try to find a Wi-Fi signal, couldn't get one. Finally got, and it turned out futility was good, not bad. Futility meant that the trials were so exceptionally powerful, it would be futile to continue trials, indeed unethical to continue these trials any further because of the magnitude of the effect size. So that was good. So that was August 4th. We, Biogen applied for the license on October 4th. December 23rd, we had this remarkable day where it was announced that it was accepted by the FDA. December 27th, everything came crashing down with that price. And so the promise that we were going to be able to give this to everybody all of a sudden became a whole new problem. And I never imagined that finances should be part of the entire development process, the entire thinking about this. And I think it's become a large part of the new quandary of medical therapy, medical development. This is going to be big. By the way, the ASO technology is useful in that it is potentially amenable to treatment of a whole lot of other diseases. It effectively abrogates synthesis of the Huntington gene, used for treating myotonic dystrophy. We're going to be hearing more about ASOs, just like we've had monoclonal antibodies. This could be a big deal. Turns out there's also other therapies for ASO. We're just now recruiting for a gene transfer experiment. That would be a nice cheap experiment when we get that one done. And other small molecule approaches. So although the ASO Spinraza program is out there first, it's not by any means the last one. We're going to hear more about it. But now with this price, a whole series of things come cascading out. I thought the success would be easy. Success turns out to be a lot more complicated. And this is why we're talking about this here, because all of the things that spill out as a consequence of unrequited success is an issue. And I've got 5 things, but I have a panel here. We want to talk about it.
Oh,
Can you just say something about the distinctions between SMA 1, 2, and 3?
Yeah,
It looks like the adults in the movie are not the same people as...
It's an excellent point, and actually, thank you. That's a lead-in for exactly what I was going to say, which is that SMA exists across the spectrum. It has these very severe babies that are destined, they look beautiful. They go home bundle of joy, and 1 week later, 2 weeks later, 2 months later, they start to get weak. And by the time they're 3-4 months of age, they're profoundly weak. The little baby you saw that was crawling, his sister was manifest at 3 months and died at 15 months of age. Incredibly cute. I helped her a few days before her death. On the other hand, we treated the boy, her brother, at 5 weeks of age, and he's not normal, but he's crawling and he's now standing and walking and can stoop and recover. So that's extraordinary. That effect size is amazing. He has a life and can be a productive citizen. On the other hand, I have there are milder forms of disease based upon the number of copies of this backup gene that manifest at later ages and have less severe weakness initially. So we have people who never make it to sitting. We call it an SMA type 1, that type designation is probably going to go away, but profoundly weak or weak demise. We have kids who can make it to sitting, but that sitting ability then is lost to generation at some later time. We have people who are able to stand. Ray Willis, who's on it in the video, is able to stand, walk, and can walk the distance of here to the bathroom, but beyond that, is going to need to have help with a scooter to get around. So every gradation of weakness, with the milder ones having a later onset. And so this becomes one of the interesting questions, because Spinraza, when it is administered before you lose motor neurons, will prevent their loss. If it's administered after motor neurons are lost, it doesn't put them back. And so we have a real quandary of the magnitude of the effect size is directly related to where they are in the course of that degeneration along the way. So this comes to one of the big issues is effect size a factor in how we should be thinking about administrating this. Okay, so my first quandary, the one that brought up this that comes with that video, is how the heck do we pay for this? Everybody is at risk for SMA. It's a universal risk factor. Everybody who has a child is at risk for having it. There's maybe 200 people in this room, 100 people in this room, so there's probably 2 or 3 people who are carriers. Carrier frequency is 1 in 45, 1 in 40. So everybody is at risk for having it. You don't know what's going to happen. When you do, you have a baby that has it. It would seem to me that the risk is universal, and hence the responsibility for paying this should be distributed against everybody who has the risk to get it. Of course, that's not the way our American insurance market works. That's a different and probably larger issue that I think this brings up tremendously. Another thing I think is important to think about is should costs somehow relate to effect size? You know, for the baby, that one that was crawling, I don't have too much problems with this massive amount of money being spent. On the other hand, for the people who are who have already lost so much and have almost nothing left to lose, I'm not certain that I can justify that kind of cost. But Solana's going to be talking about this a little bit. The meaningfulness of what you've got to give is not the same thing as the magnitude of what you've got to lose. And those are two very different issues that I think, as an ethical approach, we want to discuss. The other thing is that first in market is the same thing as being able to cash in. So if you have a mildly effective drug, but it's the first drug to manage a disease that's hopeless, then you can basically charge what the market will allow. And knowing the interests of people who have disease to get whatever it is, and my interest is in addition to get them every possible support they can, they're going to charge these gazillion-dollar charges for things that have very, very small effect size. So we've all seen this, that at least in the United States market, effect size and costs have no relationship with one another. It seems to me that this is something that we might want to attack as a community. And then the next issue is, well, if that were the case, how do we possibly measure effect size? I can measure strength, but I can't measure function effectively on any one metric. And I tell the story. Can I tell the story?
Yes, sure.
Okay, so I have this patient of mine who is a special. She has SMA 2. She's never been able to walk. She was sitting as a young girl. She would be pushed around by her friends and did everything. She tells a story about her mother let her do everything except be hoisted into the treehouse in her wheelchair. She's a special ed teacher in a pretty rugged part of town. She has 8 kids in a locked classroom because they're little rooms. And she manages their education, their sole teacher. And I asked her, how do you possibly do this without help in a locked classroom? And she says, what are they possibly going to do to me? How can they possibly threaten me? And it's like, that kind of makes sense. But she can only move her voice and her fingers this much. And so she has a big long feather that she attaches to her. When she wants the attention of the class, she waves the feather and says something. And the kids know to respond to that. By the way, she apparently only allows 2 new ones to come in each year, so the kids actually teach the other ones that they can't do. So she's exceptionally socially able. And she uses all of her skills at managing this fair group of kids who can't do that by anybody else. So she waves the feather, except that one day she lost this finger. So now she can no longer put the feather into her hand. And she came to see me about 6 months ago and said, I am now disabled because I can't use the one technique I've been using all this time. I can't teach a class. So I'm now disabled. I'm saying, what are you talking about? You can't move anything. But that, which is not measurable, turned out to be everything for her. So the magnitude and the meaningfulness to me are two very, very different things, at least in her life. That same amount of power in somebody who spends most of their time watching TV probably doesn't mean too much to her. So how do we measure that? Then there's the issue, the classic one, is triage. Okay, so we've got a limited amount of money, we've got a limited amount of resources. I have to give this my spinal tap, it's really tough. Peter Hill, front row here, is helping me figure out how to create a system where we can deliver this to folks. But what would be the proper way of prioritizing people? So I have no problems prioritizing on delta time. Treating today versus a month from now, treating today versus 3 months from now would make a difference in the outcome. Those people go first. But the moment you lose the effect of delta time, or the magnitude of the effect based upon delta time, I have difficulty figuring out who should go first. Should it be people who we can use to develop this program successfully, the easiest ones to give, who are financially won't be putting a burden on the hospital, and as a consequence we can show success and develop a following that will make the program better off. Should we use youth, young people, because they have the longest lived for this, and maybe the most to benefit from it? Should we take patients that I've known from I followed at one point 160 patients with SMA. It's down to about 80 now. Should we do our patients first as opposed to people on the outside? Should we take those people who have complicated mechanisms of delivery that Hopkins can do a good job at and other places couldn't do a good job at? So they have no other choice but to come here even though they've not seen me before. Should I do those people who have financial arrangements that are amenable to success here or commitment? And then finally, or should I take the ones that I know that safety is not an issue? Or should I take the ones that in fact safety is an issue just because we're probably better at doing it than other places that would do it in an unsafe manner? To me, the choice of criteria is the choice of patients. And I have no way in my mind of being able to stack one of these against another in any kind of meaningful or logical or ethical fashion. And even the choice of consultant I get is going to choose the issue. So who gets to rank these different criteria? And then finally, we've got a really interesting societal question. Biogen has avoided the cost, as have a lot of the pharmaceutical companies, has avoided much of the societal vitriol that comes with cashing in on this huge amount of money by giving drug away free. Hey, if you get approval, wonderful. If you can't get approval, do it again. And if they say no twice, we'll give you the drug for free for the rest of the year. Because we don't want anybody not to get the drug for lack of money. That's their story. Well, at the end of the year, we have to go back and ask the insurance company again. And maybe that program will not exist forever. We have the insurance as sort of company that they'll continue the free drug forever. But as an institution here at Hopkins, we have a tradition of never abandoning a patient for financial reasons. We will see somebody, and if for some reason they lose their insurance coverage, we'll still give them their chemotherapy because Hopkins doesn't abandon who we are. Can we do that for a $750,000 drug or $375,000 drug per year for the rest of their life? Or will that bankrupt us? And hence undermine our mission for financial reasons. There's that rule that we developed appropriately, especially since I think the greatest benefit is from the outset. So this issue about our commitment, should this cause us to question or change our commitment to patients? And I'm firmly a believer that the answer should be yes, but that's certainly against the norms of our hospital. So these are the 5 things I wanted to bring up. I'm going to just drop on you guys and my panel and see how you want to go with it. If these are any other quantities to deal with.
Well, I have another sort of clinical question that has ethical implications. Clearly, there's sort of a dose response the more drug you have, the better the effect? Does that mean that there's no response with less?
No, I think it's more a matter of timing. The earlier you give it in the course of degeneration, in fact. We actually don't know the dose. It's an interesting issue. We, for those of you in pharmaceutical stuff, you know all this. I didn't. We knew that when you give it to cells, it works. We didn't have a lot of dose adjustments. We knew when you give it to mice, one dose before they got sick, it worked for a lifetime. We knew that when you give it to a monkey at 1 month of age, you sacrifice a monkey at 15 months of age, it's still there. We knew that it was impossible to cause any side effect by giving more drug. We gave more and more and more and more to the mice, and they didn't seem to care. So there's no maximum dose. So what dose do you want to give? And what schedule do you want to give? I don't know. Let's give a loading dose. Loading doses are good. We'll give a loading dose. So we said, well, how many loading doses do you want to do? 2. 2 is good. Somebody says, well, maybe we should do 3. Okay. And somehow at the end of the meeting, the loading dose series was 4. It's like, okay, I don't. That's okay. It's just we're just figuring it out. We don't want to fail for not giving enough drug, of course. Okay, then we want to do maintenance dosing. That makes sense. Because we don't know how long it lasts and washes out. You can't measure it. It's in the cells, in the spinal cord. We can't biopsy spinal cord. So there's no way to know how long this drug is hanging around. So let's get maintenance doses, twice a year, once a year, whatever. Turned out it came out to be 3 times a year. With success comes, there's a hegemony of success. Because that protocol was the one that the drug was found to be so unbelievably successful, it's locked in stone. We cannot do any more experiments to see if you can get away with less. Because who's going to volunteer to take less? No one. I had no imagination when I was doing those theories that I was choosing forever. I thought it was just the first experiment. But here we are. So
there are no subsequent clinical trials happening on anything?
So everybody wants, yeah, so what kind of clinical trials? Obviously people want more, so there probably will be some trials to see if there's a larger dose, but not a smaller dose. There probably will be combinatory therapies to see if we can combine this with maybe the new gene transfer experiments. There are obviously other companies trying to get in space with their, so there will be, this is not the end of research. I'm not worried about being out of a job. No, there will be no more experiments on less.
But the new gene transfer therapy that's being investigated now, so the initial trials had very, very positive results, and now they're recruiting for their pivotal trial. And the idea behind this treatment is that it would be 1 IV dose, right? And that you wouldn't have to give subsequent doses for the BXS 101.
One of the other trials comes on is a single IV dose. That would be really cool. Gene transfer experiment, we're basically putting in a new copy of the gene. Again, SMA is perfectly positioned for a gene transfer experiment, which was just approved by RB. We're recruiting the other new SMA1 baby. I want that one. We'll recruit 3 here. Good.
So I guess I would just jump in on the
meaningfulness.
The discussion, yes. So the discussion on the distinction between magnitude and meaningfulness of effect. So I'm a pediatrician. I do pediatric palliative care. So my population is kids with complex, chronic, often life-limiting disease. And I learned about the development of Spinraza through my patients. As many who work with kids with chronic disease know, often the families are, they are bona fide experts on the disease. They're following the development of these drugs. They know more about them than we do. And so I learned about this through many of my patients. And once it was approved, started reading about insurance refusals for reimbursement. And so I started out asking myself the most simple of questions, which turned out to be not so simple, but the question was really, what does it mean to show that it works? So when you look at the trials, they use, for their outcomes, they use things like event-free survival, so time to death, time to mechanical ventilation, or need to mechanical ventilation, and then they use a lot of standardized, validated motor scales, so the Hammersmith infant scale, the CHOP and 10, which is another motor scale, and they consider a positive motor response as a certain incremental, certain improvement in the scores on these scales. So those are great, those are tangible endpoints, and the trials were overwhelmingly favorable, as Dr. Crawford mentioned. But I became very interested in what it means for the different stakeholders to say that there is an acceptable effect, to say that we should be essentially providing this drug and reimbursing for the costs. So what's interesting is though, although yeah.
Can I
Sure.
interrupt one?
I think you're off.
There we go. One fact I left out, I'm sorry. The approval was based upon the babies, the less than 6-month-old babies, because when you give the drug, you can now see normal development, and so it doesn't take so long to see that the kids are rolling over or sitting up and doing amazing things that babies would never do. On the other hand, the FDA, for reasons unknown to myself, approved the drug for everybody. So it's approved by the FDA for SMA of all ages, knowing that SMA is associated with a decreased amount of SMN protein at all ages. However, the effect size is only measured on the littlest ones. So we have this problem, this quandary of approval is not the same thing as data supporting.
Yeah, and so that comes back, no, that's important clarification. And so coming back to examples, so you can have patients with the same subtype, so a patient with SMA2 who is perhaps school age, who has pretty good respiratory status, who would perhaps benefit from the drug, and the hope there is that it would prevent respiratory failure and the need for mechanical ventilation, whereas another patient with SMA2 who might be a little bit more advanced in their disease course, who requires a wheelchair to ambulate and already has some non-invasive respiratory support. In this case, it might sort of just allow the person to maintain function in their fingers, and so that's a different magnitude of effect, but the meaningfulness of that effect is, I think, important to consider, and then also important to consider that the cost would be the same at all levels. So the cost of treatment would be the same for both of these patients. And so then
the drug, but not
the drug.
necessarily the cost of other kinds
of
of
other, absolutely. So the drug itself would be the same. And so then I thought, well, how do we decide what's meaningful and how do we measure that? And so I think, going to patients and caregivers is the most obvious and logical first step. And so there was a really, really great study that was done where they surveyed patients, caregivers, and clinicians, and essentially meaningful change was related to functional ability, and small changes in functional ability could lead to huge, huge improvements in quality of life. So again, that ability to use the feather, which could essentially mean opportunities for school or gainful employment, who are we to say that that's not considered meaningful and that's not considered worth the cost of the drug? And then just another example, so in the initial studies they didn't measure, for example, they didn't really look at swallowing capacity. I think some of the new studies are, but I think it comes to no surprise that people in this room that swallowing capacity is important for medical reasons, right? So we're worried about feeding difficulties, we're worried about aspiration and respiratory complications, but there was one mom in the study who was talking about her teenage daughter and said, well, it would be great if she could swallow, and didn't even mention feeding difficulties, but said, she's a teenager, she requires suction every 5 minutes, this is really awful for her, this is so embarrassing for her, it really is a huge impact on her quality of life. So I guess from doing that work, I really started to think about, well, how can we incorporate these considerations into the studies and into considerations by the different stakeholders. So I don't know that I have an answer to that question, but I think we do need to go to the community to get more insight on that.
So I have a daughter with cystic fibrosis, and so I'm aware of very expensive drugs, and this sort of chronic disease with decline over time. And I guess one of the questions I have that I think needs to be considered is if you're talking about we don't have just one path of research, right? So we're looking at all these other things. We're looking at gene replacement therapy. So what is it that you expect to gain from gene replacement therapy? Is it total, reduction of the disease, it goes away, and then so you say to yourself, well, if I can hold my kid at this level by this drug until that time that this other comes along, then why wouldn't I do that? And that is hope, and that's meaning, and that's looking forward. I think, unlike Dr. Crawford, I do see Villainy, and I see Villainy maybe in the bigger picture. I'm not saying that Biogen in particular is villainous, but I do think that when you look at the entire picture of how we do medicine and how we develop it and how it's paid for and the inequities and the different tiers of availability of medication, it's quite alarming. And I think ethically reprehensible. So in that state, I do see villainy. And I think that as people that are involved in this, either as caregivers or people with a disease or people in this room or at this institution, anybody that has the power to speak to it should be speaking to that. And I know everybody doesn't have one voice, but certainly I think there is a way. I think we're smart enough to come up with a way that's better than what we're doing now. I think it is also one of those things where you talk about, that this research doesn't just help this disease, it's transferable, and I cannot believe that these companies are not taking advantage of that and saying, aha, I've got something, I've probably got a patent on it, and I'm going to go after some other diseases. So I think that their costs over time become less and less, and I think that we have to consider this hopefulness that we hold in one hand with all these different, possible attacks to this disease, and then what we're withholding on this side because somebody is deemed more worthy than others based on their trajectory. I also wonder where we are in sort of insisting upon screening for the carriers, so that in the future, if we know that people are carriers, we can have good genetic counseling, and we can get them this drug, instantaneously. And I wonder too the cost overall, so if you can address this within the young children, what does that mean? The cost of the drug vis-a-vis the cost of other medical treatments over the life of that patient. So those are some questions I have.
A lot of things to address there. So I'm not completely Pollyannish. I definitely see villainy. The point I wanted to make, at least in that particular narrow statement, is that the search for villainy is not the solution to this problem. We're not going to solve this by trying to find something to point a finger at. Yeah, one of the early kickoff meetings was at the Beverly Hills Hotel, and I was kind of perturbed that they were spending that much money on me. Because I knew that money was going to go factor into the cost of medicine and eventually it was successful. So and their executives were paid too much and all that kind of stuff. On the other hand, it is frightfully expensive to develop these things. And so, if we take off that part of it and cut it down to $500,000 as opposed to $750,000, we still have the same problem. And so I see huge liability in the pricing of drugs when the effect size is small. If a company sets out to create a new drug for a certain market and the potential for benefit is small, I would say they don't get rewarded by having these kind of usurious pricing. If on the other hand, they're swinging for the fences and they get it, I think we should be rewarding them for that kind of high risk behavior as this was. And so from that standpoint, villainy is not the solution, but it certainly exists and needs to be rooted out when we find it. And I think that part of the process that we should be doing as a society is trying to ferret out when villainy, if we want to use that, I like that, when it has a contributor to the healthcare crisis we have. And hence we would be better suited to pay for these high development costs in small populations when necessary. Newborn screening, February. Yeah, newborn screening February. The Rust recommendation will be made. They have to vote February 16th or something, and so it's highly likely. I think it's almost a lock that the SMA will be included into the uniform newborn screening program. And so babies are going to be born healthy, go home. And 2 weeks later, 1 week later, mom will get a phone call. By the way, your baby has this awful dread disease that you've never heard of. One of the interesting quantities we're going to be having is, I'm actually looking forward, this is like the end of polio, infant polio. It's fantastic. On the other hand, the installed base of pediatricians and doctors who've been caring for these SMA1 babies, they're just so unbelievably hapless and hopeless and engaging. Those docs are going to be aging out, and our memory for these very sick babies is going to disappear. But the babies are still going to be there, so it's going to be like, what are the crude terms? what do you want, lady? You want us to take this baby and stick needles in the back for the rest of their life, or I fully expect that there's going to be some pushback from parents saying, my baby's perfect, you can't do that. What are we going to do? Is that an actionable offense? Should I take that baby away from, or some sort of legal constraint to say you in fact have to do that because your judgment is clouded? Wow, that one's coming.
And what are the cost implications of newborn screening? So
Yeah.
when we think about anticipatory costs, there'll be a subset of babies who would not yet have to be treated for a while.
Yeah, so we just submitted the paper. At the mildest end, we don't know if there are going to be some asymptomatic ones. So there is a guideline protocol for following for early signs of SMA. But if we wait for the early signs of SMA, that means that they've already suffered a lot of neural damage. And so the cost of not treating the mildest is committing some of those, something less than mild ones, to getting the maximum benefit from the therapy by giving initially.
But I'm talking about preventive. Will there be a demand for preventive treatment that adds to the cost?
Yeah, so the access, the gene transfer, we can try to do it. So the issue of carrier screening, there was a big push to use carrier screening. In fact, most mothers are asked on a pamphlet, do you want to have screening for this dread disease? Yes, no. And I think most of the answers are, if they can assign it to insurance, yes, and if I can't assign it to insurance, no. And so a fair number of mothers in their first visit to the OB are being asked that question. Now, if you're screening positive, then you got to bring the guy in. And so that's a little bit difficult, because sometimes they come in, sometimes you don't really want to do that. Sometimes they're, a different guy. There's this non-maternity is about 3%. And so that's a ticklish little question you have to bring up. It's vastly more likely that the father is not the father than that the kid has SMA, for example. And then there's the issue of people refusing to do it, and some other sorts of things. So newborn screening is the idea that we would give people the options to do this, but how can you be really informed about this dread disease when you've never even heard of it?
Okay, so I was on
Sure.
the state
Yeah.
council for hereditary and congenital diseases for a while, and we would review the newborn screening. And so I remember when the CFG was added to that screening. And I think these are questions that are always brought up whenever you indicate, for newborn screening. There's always those questions about, well, what does this mean? What are they going to treat? What about false positive? All those sorts of things. However, I think by and large in the state of Maryland, we've seen that newborn screening and the effective way that our state does get to and deal with parents that have children with any number of these screen diseases is pretty effective. And so, there are questions, there are always questions, but I don't know that those issues are enough to not do it when you see the benefit.
So newborn screening, I have no question whatsoever. Newborn screening is unequivocally, but carrier screening is one that's complicated.
Well, it is complicated. I know that I would have wanted to have carrier screening in advance, but that's just me, because I know that I'd rather have my kid with CF treated from the get-go than not.
So I had this mother who carrier screen positive, get dad in. Dad came on the wrong day, and so he couldn't be done. So he came on the second day, and they asked him to put down $700 for the screening, because the person over there didn't know how to read it, just like this, and so they got pissed off and he left. And so the mother went to the OB and says, what do? I'm carrier screen positive, and he went through the things and says, well, your chances are only 1 in 200, so we don't really have to worry too much about that. We don't know if he's a carrier, and if he is, then it's 1/4 of that. So it's 1 in 400 or 1 in 200. So it was probably okay. Don't worry about it. Baby's born, looks healthy, fantastic. Mom was worried the whole time. Yeah. Baby looks good. Goes home, and then 3 months later starts to get weak and indeed has SMA. So she's been through the ringer like 3 times back and forth. And the reason why I find that an interesting story is because I only know about her because the kid was affected. By rights, this same story happened 200 times, but for the one time I learned, how much damage are we doing to people that we're not measuring when we do that? Joanne.
So this baby, I saw it preoperatively, and so I saw this baby preoperatively, and so went through this whole discussion about what we were going to do, how we were going to do
That was a
it.
different milestone.
So we started one last week that was very similar, picked up like a 3 or 4 months old, finally got to us just before 6 months old, and had the first injection last week. And the kid really is weak already, he doesn't move the legs, and she's an adorable baby, just really engaging little girl. And the dad was arguing with me about why we needed to do this, and why it was important to get the drug early, and what about the anesthesia risks, and he was giving me significant pushback. And part of me wanted to say, are you just throttle him, are you nuts? This is the best chance you have for your child, and you should be thankful we're doing all of this to try and give you and your family back some kind of a regular life. It's already not going to be normal, the kid's weak. So unbelievably, parents don't always make the right decisions.
I would get on, or I would like to open it up to other folks, because we've been over a lot of stuff. I've worked.
Could you address the issue of how the reimbursement, payment, and so on is managed in, say, some of the socialized Mexican countries in Europe, England, the Scandinavian countries?
I could, but I would probably botch it. So in some countries, so obviously the cash cow is the United States. That's where they've brought it to approvals. European FDA has approved it. In Europe, the cost conditions, as I understand it, include a decision about how much money they put into development, what was the risks involved in that development, whether it's the first in class, and most importantly, the effect size. Effect size is not included in pricing here in the States, and I think that is something that as a nation we need to address completely, otherwise this is going to swamp us. So yes, and so as I understand it right now, Biogen saying this is what it's going to cost in certain countries like Denmark. One of the Scandinavian, I think it's Denmark, has said, okay, we're not going to do it. Nobody in this country is going to get it because we as a nation can't afford them.
Yeah, so currently in Canada, so the drug was approved by Health Canada, and it's now going through a common drug review committee, so pricing pathway is very different, so they do a cost-benefit analysis, and then they decide how to price the drug. And they have recommended for now that it be available only for certain subtypes of SMA1, so the PRSMA community is obviously fighting back against that. And in Quebec, because of course you guys have to be different, they actually have said that they will not reimburse the drug even for patients with SMA1. So it's actually not going to be reimbursed.
By the way, from a cold actuarial standpoint, this drug will not cover the cost of having SMA. So we will not save money, although there will be savings in terms of non-payment for all medical care, the lost productivity, the family costs, the educational costs, all that kind of stuff, which, by the way, are not borne by the medical insurance domain, and it's not measurable. There's a total societal cost. The cost of Spinraza outweighs the total cost of the disease without it. On the other hand, you can argue that living in those broken bodies and all the turmoil that comes out and the risk that we have supports a societal commitment to this, even if we can't recoup it in that kind of cold actuarial sense. I'm of that persuasion as long as we can modify.
There's also the likelihood of creating a two-tiered system where only people who could afford it, Canadians can come get it here if they can afford it.
Peter, you want to weigh in on any of this? You want to get called out? Yeah. Peter Hill.
No, just to add that I think from the hospital perspective, we're trying very hard to accommodate and support Tom's effort, Tom's work, and working out the best mechanism of delivery, both here at the hospital and outside in non-regulated space to help with those issues. And so from our perspective, we're fully supporting and just trying to create the infrastructure. And then the whole issue of which patients to do in which order is really outside our hands, but certainly willing to that determination.
I'm really lucky to be in Hopkins, and I can't say this enough. And we're all lucky to be at the institution. The support of the institution for addressing this issue. In fact, even the idea that finance has become part of the whole development program of getting this to people is something that most of my colleagues around the country are feeling abandoned. And I don't feel abandoned. And it's really a testament to some extraordinary leadership. And I'm not just saying that because I need something, but I do. But I do need something. It happens to be true.
So, just as a curiosity question, so how many patients have been treated since FDA approval, and how many of those have paid versus how many of those have gotten the drug for free from Biogen? So is Biogen actually making any money despite the cost, or where does that actually fall presently?
So really good questions, and a lot of that is tightly held, and frankly, I don't pay too much attention to it, but I got my head down on this. I think it's somewhere about 1,000 patients have received it, something between 1,000 and 1,200, and my guess is that somewhere around 67% are getting it paid for, and the remainder are in this free drug program. And I am personally interested in seeing if we could leverage the free drug program to make a case for why the pricing should be related to effect size. Because if it were cheaper for those people who manifest less benefit, it would seem to me we could make a better case to insurance companies for why they should pay for it. But God knows I don't have any sway in this. Yes, Peter?
Well, I'm wondering if they already figured into the price, the percentage of free drug that they anticipated giving. So that's already built in. These are very smart people. I imagine they would have done that.
The other thing I did learn about this is these guys are really smart. They're in about a dozen different ways. Little things that seemed like they didn't make sense initially. After the fact, said, "Oh, that's why that was." They're playing three-dimensional chess. Well, this is the academic researcher.
Well, I also wonder if they had the opportunity to really influence FDA's decision to approve it for everybody.
Well, absolutely. They put in saying that they wanted to approve for everybody. Of course, they wanted the broadest possible label. I'm stunned that the FDA gave them the label without a requirement for additional testing. That was the stunner. I think FDA was in an awkward spot because they had just gone through a certain imbroglio with another neuromuscular drug that put them in a really awkward spot. So this was a company that did it right, did outstanding, effect size was good, everybody was happy. So why not give them broad approval? They were they needed a win at the time.
Anybody else?
Stunned people into silence.
So one of the folks in the panel mentioned that they thought the executives were paid too much at the drug company, and I'm interested in the question of what a fair salary would be for executives at a company producing this drug.
Yeah, right. How much is that picture worth? How can we possibly do that? I mean, obviously they have to go to the capital markets, and they have to raise the money on Wall Street, and the people on Wall Street don't care if we're talking about a skin condition or a fatal disease of babies. They just want to know where the profit is. I remember one company that I had worked with before because I had another idea for it. They bragged about, my company, you want to come to us because we're the best in the world at killing bad ideas. Like, what are you talking about? Well, we buy 200 programs a year, and we're going to get rid of 198 of them and save the 2 that work. It doesn't matter what they happen to be. We're going to save the 2 that make money. But what about all the patients that could have been benefited by this program that you set aside? We sell those off to somebody else. They can deal with it. We're only going to go with the good ones. There's a cold pecuniary aspect to drug development that the people who know how to manage that, hats off to them, because we have to deal with that end of things. And here I'm just trying to do right by patients. Where's the interface between these two cultures? How much should we pay them? That's above my pay grade. One of the jokes about neurologists is that we're the best in the world at not answering questions.
You know, I'm thinking about the years of work I've done on the ethical issues and carrier screening generally. I've been working in that space for a long time. And a lot of what we've already touched on sort of has been true for a long time. You know, when and under what conditions should we mandate carrier screening? Issues of, you know, paternity testing and issues of whether informed consent can actually be adequate, and issues about, you know, implications for termination of pregnancy. All those issues have been around for a while. What strikes me as really new here, and I don't know if there are genetic counselors in the room who could disagree with me about this, but the degree to which cost actually can figure into the informed consent process now. You know, that whether or not you want to be screened, whether or not you actually want to have a child with SMA, we can attach a dollar figure to the implications of what it's like to care for that child now. I don't know if that's been true. Any genetic counselors in the room?
And you know, we talked about the obvious financial barrier, which is the cost of the drug, but then there are all those other financial costs that stem from the fact that it's only available in limited centers, right? So parents having to travel to get the drug for their children, sometimes hours a day, the impact on employment, and then also just practical barriers to access. So there are certain children with spinal fusion or scoliosis for whom they might simply not be able to receive the injection because it's an intrathecal injection, or patients with poor respiratory drive going in who might need a post-injection hospitalization, and so there's the issue of resources there, and so there are other barriers to care that are sort of more indirect, but still exist and are still important.
So I want to thank our panel for a very provocative conversation, and I'm sure have left everyone with lots of unanswered questions that we're going to